facilities are available. BNP is one of the helpful investigators. The BNP is very high. It invariably indicates patient is dyspneic due to heart failure. In fact, you wouldn't jump and do a BNP as the first line investigation. You go by history examination and other basic investigation like ECG and just X-ray to start. But if the facilities are available, if you are in doubt, BNP is one of the very helpful investigations. Invariably, BNP would be high. If the BNP is normal or less than normal, makes heart failure unlikely. Cyanosis is present. The patient is cyanosed. What do you think? Is it more favorable bronchial asthma or heart failure?
True, bronchial asthma.
I think it's more favorable bronchial asthma. Anyone who thinks it's false? Dylan, what do you think? True or false?
True, sir.
It's true. Okay. So, what do you mean by central cyanosis? What is the definition of central cyanosis? When somebody would be centrally cyanosed? Around when somebody would be centrally cyanosed?
When there is a cardiovascular or respiratory system pathology, deoxygenated hemoglobin more than 5 grams per deciliter in capillary level.
Good, yeah. When deoxygenated hemoglobin is more than 5 grams per deciliter. So that could happen in any cardiovascular or respiratory conditions. But more common, mainly respiratory conditions. But having said that, some cardiovascular conditions also could give rise to central cyanosis. So what are the cardiovascular conditions you know of that could produce central cyanosis?
Congenital heart defect like tetralogy of Fallot.
Yes, tetralogy of Fallot is correct. Can any congenital heart defect present with central cyanosis? Is it common for all the congenital heart diseases to present with central cyanosis? So any type of
right to left shunt.
Yes, when there's a right to left shunt, or in cyanotic congenital heart diseases, isn't it? Tetralogy of Fallot, isn't it?
Yes.
And then even the acyanotic congenital heart diseases like ASD and VSD, when it's there uncorrected for a long time, if they go into adulthood, the shunt can reverse and patients later on may present with right to left shunts later on, isn't it? That is called Eisenmengers. So in those situations, even the conditions of cardiovascular, they may present with central cyanosis. But more commonly, what are the respiratory conditions that may present with cyanosis?
Type 2 respiratory failure.
Yeah, commonly patients with type 2 respiratory failure, patients with COPD, and any patients who have been chronically hypoxic, they become cyanosed centrally. But even in bronchial asthma, when the condition is very severe or life-threatening, they may develop cyanosis. It's a very poor prognostic feature. Patients with LVF, left ventricular failure, they are very unusual to develop central cyanosis. unless they are chronically hypoxic. So yes, I agree. So it's true. Severe asthma, they may become sinus. But this response would have been much better if it had been central cyanosis than just mentioning sinus, because anybody can develop peripheral cyanosis, isn't it? Even in cold weather. So D, what do you think? Pulsus paradoxus. Pulsus paradox. What is pulsus paradoxus? Harsha, what do you mean by pulsus paradoxus? And if somebody has pulsus paradoxus, what does it favor out of LVF and bronchial asthma? Damindi, if there's pulsus paradoxus, what does it favor and what do you mean by pulsus paradoxus? Darshani, what do you think? Pulsus paradoxus is actually a misnomer, isn't it? If somebody has a systolic blood pressure reduction more than 10 mercury millimeters during inspiration, that's called a pulsus paradoxus. In fact, actually, it's an accentuation of the normal physiological response during inspiration. During inspiration, anyone's left ventricular stroke volume would drop. Why? Due to negative intrathoracic pressure, more and more blood is diverted into the right heart. So, right ventricular stroke volume slightly increases and left ventricular stroke volume decreases slightly with inspiration. But in certain conditions, that inspiratory drop in systolic blood pressure is more than 10 mercury millimeters. So one such condition would be severe asthma, mainly occurs with patients with obstructive airway disease like COPD and asthma. So if somebody has pulsus paradoxus, it more favor for bronchial asthma than LVF. So you could take it as true, isn't it? Then what do you think about the last one? Small pleural effusion. True or false? Rashini, what do you think? Small pleural effusion is present.
It's false, sir.
It's false. You think if there's small pleural effusion, it's more favor for LVF.
Yes.
Right. Good. Yes. If there's effusion, it's more favor for LVF. Why? In asthma, effusions are not seen unless there's a. So, which side where the patients would develop effusions more in LVF? Right or left? Rashini, which side is more common to develop effusions in patients with LVF? Right side or left side? Usually they.
Hello, may this.
Hello? I didn't hear. What's the problem? Right side or left side? Pleural effusions are more common in patients with LVF on which side?
Right side.
Yes. Good. Initially they develop right-sided effusion. They may have bilateral effusions even. Fine. Shall we move on to the next question?
Sir, excuse me, sir. There's a small problem. I think we have discussed these questions before in your revision class with us.
These questions were discussed, is it?
I think so, sir. Yeah.
Fine. So we can go a little further down.
You stopped at
Where did I stop?
Legionella and typhoid. Question on dengue. I haven't written the number.
Probably is this one 20? 35-year-old.
Yes, sir. Question
sir.
20.
After 20, I have done with you. Have I
Yes,
done?
sir. Yes, sir.
21.
Oh, good. So you could remember after. So this one I have done with you, the question on dengue.
Yes, up to 21. Which answer was fusiform malaria?
Right. So I have done after 21. That's fine. So we'll go to 20. Okay, that's good that you have made 22. Have I done 22 with you? A 40-year-old female complains of shortness of breath of 6 months. Have I done that one with you? A lung function test revealed FE1 to FEC ratio of 65. ඒක කරාද? Which
No,
of the
sir.
following කරේ නෑනේ?
Goodness.
Fine. Okay. So that's good. Oh, good that you have remembered. I have done. So that's fine. So what do you think? Which of the following are possible causes for her shortness of breath? So what do you think? So this checks whether how familiar you are with the lung function test or pulmonary function tests. Somebody has a shortness of breath for 6 months. Chronic shortness of breath. They are mentioned whether this is intermittent shortness of breath or progressive shortness of breath. Could be one of either. But in the pulmonary function test or lung function test, FE1 to FEC ratio is 65. So let's see. COPD. Is it true or false? Yeah, what do you think? COPD, is it true?
True.
Anyone think it's false? Why do you think COPD is true? So this mainly gives the patient with the obstructive airway disease. So patient has a reduced FE1 to FEC ratio. If it is less than 70, we take it as abnormally reduced ratio. So somebody with the shortness of breath for 6 months having an obstructive pattern. So COPD is true, I agree with you. Because it favors the given finding. Pulmonary fibrosis. Pulmonary fibrosis.
False.
So what do you expect in pulmonary fibrosis?
Normal FE1 to FEC ratio. Restrictive.
Yes, good. You expect a restrictive pattern in pulmonary function tests. Both FE1 and FEC will decrease in patients with pulmonary fibrosis, but reduction in FEC would be more, so that FE1 to FEC ratio is normal or little bit increased in patients with restrictive lung diseases, isn't it? So you won't expect patient may have shortness of breath going on for 6 months, but you won't expect these pulmonary function tests in those patients. Isn't it?
Yes.
So good. So pulmonary fibrosis is wrong because you expect a restrictive pattern in bronchial asthma.
True.
Good. Bronchial asthma is true again. As I have mentioned, they mentioned patient has a 6 months history of dyspnea, may or may not be progressive. So in bronchial asthma, somebody may be having dyspnea which is intermittent, and in between there is a patient may be well. So at the time of an exacerbation, this would be true, isn't it? Again, bronchial asthma falls under the category of obstructive airway disease, isn't it? LVF.
False.
Okay, good. LVF. What is the pulmonary function test pattern you expect in LVF?
No. Normal FV1 to FVC ratio.
Yes, you wouldn't expect an obstructive pattern like this. Good. Anemia.
False.
Good. Because somebody can be short of breath due to anemia, but you won't expect an obstructive pattern of pulmonary function tests in patients with anemia. If I give a response like this, if somebody with the interstitial lung disease with rheumatoid arthritis, can they have this pattern? Somebody with interstitial lung disease, you get response like this. True or false?
False. Restricted disease.
Yeah, it's restrictive pattern.
Yes.
Good. So we move on to the next one. Recognized features of miliary tuberculosis include recognized features of miliary tuberculosis. Widespread calcification on chest radiograph.
False.
Fine. So what do you get if it is not widespread calcification? What are
Ground glass appearance in the chest X-ray.
glass appearance in the chest X-ray? Why do you call it as miliary tuberculosis? What do you mean? You get a millet seed pattern appearance in the chest X-rays. Millet seed pattern, not necessarily ground glass appearance. It's widespread millet seed pattern, not calcifications of ground glass. So it's not widespread calcification. It's false. Pancytopenia. What do you think? Miliary tuberculosis.
It's true.
Yes, pancytopenia could be a feature in patients with miliary. Why do they develop pancytopenia?
Due to bone marrow involvement.
Due to bone marrow involvement, because it's a disseminated infection, isn't it? Involving liver, bone marrow, lungs, isn't it? So patients may be pancytopenic at the time of presentation. So that's true. Hepatosplenomegaly. What do you-
It's true.
Yes. respiration is one of the recognized features. That's correct. Strongly positive mark. Yes.
False.
False.
Anybody who says is true. Strongly positive mark. Mark indicates a potent immune reaction. Underlying immunity has to be fairly good if somebody to develop a positive heart reaction. So somebody with a very strong immune response for tuberculosis, they won't usually go on and develop miliary tuberculosis. So that's same with patients with HIV and some other underlying primary or secondary immune deficiency. If they develop miliary tuberculosis, usually not won't be very strongly reactive. So somebody has a strongly positive monitor, it's very unlikely they have a disseminated pattern of TBC. That's so to be the miliary. Granuloma in the liver. So what do you think? If you do a liver biopsy, would you expect to see granulomas in patients with miliary TB?
It's true.
Good. Yes, they develop granulomas in the liver. What is the characteristic feature in their granulomas?
Caseating granule.
Yes, good. Caseating granulomas. So basically, they develop caseating granulomas. Fine. So shall we move on to the next one? Following features. Following are features of life-threatening asthma. So this is one of the things you have to know by heart, isn't it? Features of severe exacerbation of asthma and life-threatening exacerbation that has to be very well familiar with you. So what is cyanosis? Somebody
True.
cyanosis.
True.
Yeah, very good. Silent chest.
True.
True. Low partial pressure of carbon dioxide. Low PaCO.
False. False.
Yes, anybody think it's true? Low PaCO2. That's the commonest pattern in arterial blood gas analysis you see in any patients with asthma. Usually patients with mild to moderate or even severe exacerbation of asthma, usually they have a good carbon dioxide washout. They will wash out carbon dioxide and carbon dioxide will be low most of the patients with asthma. So that's a satisfactory response. With increasing respiratory rate, they wash out a lot of carbon dioxide. So if somebody has a low PaCO2, you are not much worried. So that's the usual expected response in patient with asthma. But if somebody has a normal or elevated PaCO2, that indicates a poor prognosis. That indicates patient might need intubation soon if you are not going to treat that patient aggressively. So if somebody has a normal or high PaCO2, that indicates a severe or life-threatening asthma. So low PaCO2 is not a feature of life-threatening asthma. Respiratory alkalosis. Is it a feature of
False.
life-threatening asthma?
False.
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 So why do you think it's false?
Because when respiratory alkalosis occurs when the patient is hyperventilating and That means
Good.
there's good effect.
Yes, very good. Yeah, that's the answer. So, respiratory necrosis develops when somebody was found carbon dioxide. So that's a pattern you see in patients with hyperventilation or some mild to moderate asthma, not somebody with a life-threatening asthma. If at all, they would develop respiratory acidosis, isn't it? The respiratory acidosis was there, you would have marked it true. Respiratory alkalosis, you are not much worried. Hypotension, low blood pressure, Rashmi, what is it?
True,
I-
sir.
True. Yes. Good. Somebody has a low blood pressure that favors life-threatening asthma, isn't it? Alopecia is seen in. Have I done this one with you? Alopecia. Make career. Alopecia is seen. Fine. Then let's see. Alopecia is seen in discoid lupus erythematosus or DL. What do you think, Oshadi?
True.
True. Good. DLE, you get alopecia. They mainly develop scarring type of alopecia in DLE. So this is one of the questions from your dermatology. Good. So I agree with you. It's true. DLE, even SLE, they develop alopecia. Then next one, congenital adrenal hyperplasia. Dealing with
False.
Erandi. Congenital adrenal. Anyone thinks it's true congenital adrenal hyperplasia? Adisha, what is it? Anything that can happen to your hair, pattern of hair distribution in patients with congenital adrenal hyperplasia?
Hirsutism.
Yes, they can develop hirsutism. What happened to scalp hair?
Boldness.
Why do they develop baldness? A baldness they can develop when?
Due to high levels
Due
of
to
androgen.
high levels of androgen.
Yes, they have a little bit of high level of androgen signaling. So they develop androgenic type of alopecia. And alopecia can be categorized in several ways. Mainly it's categorized depending on whether the patient has underlying scarring of scalp or not. So main two categories, one way of categorizing whether the patient has scarring or not. So scarring alopecia and non-scarring alopecia. Conditions like DLD and fungal infections, mycosis of the scalp, they do scarring alopecia. Non-scarring alopecia, there is no underlying scarring in the skin. Conditions like androgenic alopecia and iron deficiency anemia, hypothyroidism, they develop non-scarring alopecia. So patients, people who has androgens or androgenic excess, they might develop a main pattern type of baldness or androgenic alopecia. So that's True even in congenital and renal hyperplasia as well. They would give androgenic type of alopecia. Any other condition that patient may develop a non-scarring alopecia?
Radiotherapy.
Yeah, with radiotherapy, they might not necessarily radiotherapy to head and neck region, and especially chemotherapy, isn't it? With chemotherapy, they lose hair, isn't it? Then hypothyroidism, iron deficiency anemia. So if people comes to you with alopecia, one of the main things you would like to screen them for is by doing a full blood count and a thyroid function test. Two of the main correctable reasons for alopecia would be those, isn't it? Then, if the TSH is high, you would treat them with some thyroxine. If the patient is deficient in iron, you might give some iron, isn't it? So their hair will start growing. But it depends on the cause. If the patient has a scarring alopecia, depending on the underlying cause, you may treat and see if there's a mycosis, you would treat with antifungals, systemic prevalent. And if there's DAP, you would treat with steroids. So the patient will respond. So see what you think. Treatment with minoxidil.
False.
Why do you think it's false? What happens with minoxidil?
Minoxidil is it increases the hair growth.
Very good. Yes, it increases the hair. Pipetol is one of the treatments for alopecia.
Alopecia.
There are minoxidil lotions or local applications of minoxidil where you treat the patients with alopecia. If you give some minoxidil local application, you expect the hair to grow, isn't it? So minoxidil, other way around, it checks whether you know some treatment for this alopecia areata. Commonly alopecia areata, they treat with minoxidil. So it's false. Treatment with minoxidil results in hair growth. Then next one, PCOS or polycystic ovarian syndrome. Do they have some alopecia?
It's true.
Good. Yes. Patients with PCOS have some alopecia. Fine. Then the last one, irradiation, X-irradiation.
True.
Yes, good. That we have discussed already. Radiotherapy and chemotherapy both can cause alopecia. Sometimes they can make the question a little bit difficult by making the stem like non-scarring alopecia is seen in, or scarring alopecia is seen in, and some responses. So divide alopecia into two main categories, which are scarring and non-scarring, and try to remember a few causes under those two entities. What are the causes of scarring alopecia and non-scarring? And some years they have asked like that as well. So in a patient with cardiac failure, elevated JAP indicates right-sided dysfunction. True or false?
True.
Good. Yes. Elevated JAP indicates right heart failure. Basal crepitations occur in LVF or left ventricular failure. True or false?
True.
Fine. So what are the other clinical features of LVF? Behind a apart from these interpretations, what else, what other physical examinations you might see in patients with LVF? You might have to remember some of the bedside examinations and things, mainly from the clinicals. Most of these are MCQ true and false you can answer from the clinical appointments as well, isn't it? This is also one set of situations. Features of LVF, that's bread and butter, isn't it? Cardiomegaly, tachycardia, S3 gallop. Those are the features in LVF. Collapsing pulse. In a patient with cardiac failure, a collapsing pulse develops.
False.
What are situations you might get a collapsing pulse?
PDA and aortic regurgitation where the pulse pressure is very high.
Yes, very good. When the pulse pressure is high, or if the patient has hyperdynamic circulation, situations like thyrotoxicosis, pregnancy, even high fever, aortic regurgitations, PDA, AV fistulas, patients with AV fistulas, they have a collapsing pulse. Sometimes a patient with the collapsing pulse may have an underlying heart failure also, especially high output heart failure, but it's not mainly a feature in LVF. Hepatic enlargement is an expected finding. Anjula, what do you think? Would you expect hepatomegaly in patient with the heart failure?
Right. Okay.
Yeah, isn't it? So hepatomegaly only where enlargement occurs in patients with right heart failure, isn't it? Patients with tricuspid regurgitation, maybe they develop hepatomegaly which is pulsatile. Pulsatile hepatomegaly or a pulsatile liver is a classical feature in patients with tricuspid regurgitation. But any patient with the significant right heart failure, you expect liver to be enlarged, isn't it? That's the one of the abdominal examination findings in those patients. Hepatomegaly, isn't it? Elevated JVP, hepatomegaly, ankle edema, those are the features of right heart failure. Patient develops orthopnea. True or false?
True.
Yes. Good. True. Orthopnea, paroxysmal nocturnal dyspnea. Those are the features of left ventricular failure, isn't it? So sometimes you may be questions features of our right heart failure, features of left ventricular failure, or features of congestive cardiac failure. So carefully check about the stem. If they commonly ask features of cardiac failure, it may be features of either right or left heart failure. So that's one of the common things you could be asked. So what is the opposite term of orthopnea?
Platypnea?
Yes, good. So where would you get platypnea? Is it a feature of heart failure? Where would you get platypnea? Orthopnea is actually worsening shortness of breath when you lie down, isn't it? Platypnea, you get worsening shortness shortness of breath when you sit up. And while in the lying down position, you are more comfortable, isn't it? So as a home, just try to find out where would you get platypnea, right? May not be asked on you commonly because it is one of the rare conditions. So platypnea is opposite. So very good. So 35-year-old extra, 35-year-old female with AF on warfarin has presented with sudden onset weakness. She was very drowsy on admission. Which of the following investigations will help in the immediate management? A young female presenting with AF while on warfarin, sudden onset weakness and drowsiness. And question asked about immediate management of the patient. ESR.
Fourth.
Yeah, you do an ESR later on, but it may not help in the immediate management of the patient. You may request an ESR later on, but may not change your immediate management. Then a non-contrast CT brain, would you do?
True.
Yeah, you would go for an urgent non-contrast CT brain, isn't it? So why you would go for a non-contrast CT brain? Somebody with AF on warfarin present with the acute sudden onset weakness and reduced level of consciousness or drowsy. Why do you want to do a CT?
Intracranial hemorrhage.
Good. Yes, we need to rule out a hemorrhage, intracranial hemorrhage, but sometimes you might see some other findings like a large MCA territory infarct. That mainly depends on your INR, isn't it? If the INR is less than therapeutic range or subtherapeutic, patient may develop infarctions. But if it is high or if the patient is overcoagulated, over undercoagulated, or over anticoagulated, then patient may have a bleeding when I see it. So, prothrombin time, would you do a PT?
True.
Good.
True.
PT. Yes, I would be interested to find out what PT would be in those patients. Because management differs if somebody has a PT or something like 7 and ICH, we might have to correct or reverse the warfarin effect very quickly. But if somebody is undercoagulated with the PT like 1.2 or 1 PTINR, then you might consider increasing anticoagulant dose. Echo.
It's true.
Why you want to do an echocardiogram? Why do you want to look for an echo?
Exclude thrombus in the left atrium as patient is having atrial fibrillation.
Yes, you want to exclude or rule out the cardiac source of embolus. Cardiac source of emboli in this patient is echo. You would be really interested to do, and that's fine. So that's true. Lipid profile.
False.
Yes, lipid profile. You are not really interested to know the lipid profile on an urgent basis. You can request it later on. It's not an immediate concern, isn't it? I'm not worried about lipids immediately. Maybe later. Number 28. Question number 28. SLE. SLE is characterized by widespread granuloma formation.
False.
Widespread granuloma formation. Anyone who thinks it's true? It's not a granular metastasis, isn't it? Widespread granuloma formation is a manifestation of granular metastasis like tuberculosis, inflammatory bowel disease, and sarcoidosis, and so on. So there is an entity called granular metastasis where you find widespread granuloma in various parts of the body, in various organs. But SLE is not such a candidate. If at all, if you suspect SLE, do a biopsy. For an example, in intestines, liver, skin, granuloma, you may not suspect SLE. It favors something else, like something like sarcoidosis, tuberculosis, or inflammatory bowel disease. Joint involvement in the majority. True or false?
False.
True.
What you have seen so far, have you seen patients with SLE? In the patients you have seen with SLE, did they have joint involvement? Majority of them, or only minority had the joint involvement? What type of joint involvement do they have in common? What type of joint involvement?
Small joints of the hands, proximal PIP.
Yes, mainly it's a symmetrical small joint type of joint involvement, isn't it? And if you do an X-ray, do you commonly see erosions or not?
No
erosions.
Yeah, they develop non-erosive type of arthritis. Non-erosive type of arthritis, which is usually involving small joints of hands. And can they develop some abnormal finger and joint posturing?
Yes.
What's that? Any abnormal joint
Jacquard arthropathy.
Yes, Jacquard's arthropathy, isn't it? It's a non-erosive type of arthritis and correctable or manipulable joint deformities called Jacquard's arthropathy. In fact, actually, when it's come to muscles, so SLE, they get multi-system involvement, isn't it? Musculoskeletal, hematological, then intestinal, CNS involvement, renal, cutaneous, because various organs or various systems get affected in it. Commonly, skin, musculoskeletal, renal, then CNS, hematological, even GI, and so on. But liver involvement is less common in SLE. So, under musculoskeletal joint involvement is one of the common features. So, majority have some joint involvements, so we mark it as true. But the pattern is a non-erosive type of arthritis, symmetrical small joint involvement. Nervous system involvement in less than 10%. So, what is it?
False.
Then what's the involvement?
More than 50%, sir.
Nervous system involvement. Where did you find it? More than 50%.
Around 60%.
It's mentioned in Kumar. So there are different thoughts in this. Some mention it's around 40%. Some mention it's around 50%, but in Kumar Clark mention it's around 50%. That's fairly reasonable. So usually somewhere around 40 to 60% of patients have some CNS involved. So it's a fairly high percentage. So anyway, whether it's 40 or 60, anyway 10% value is false, isn't it? Less than 10% value is fairly much higher than 10%. Photosensitivity. Are they photosensitive?
True.
Yes, they develop photosensitive rashes, isn't it? Mainly in the male area. And so one of the main things you ask, the photosensitive rash, one of the cutaneous manifestations. Good. So positive rheumatoid factor in majority.
False.
Yes. Some of the patients with SLE may develop positive rheumatoid factors, mainly when they go on to develop some overlap syndromes. SLE-RA overlap. So there are patients who has features of two or more connective tissue disorders at the same time at given time. One such overlap would be SLE-RA overlap. But that's in the minority, not majority. Likewise, you may get questions on different system involvements in SLE. For an example, someone asks hematological manifestations of SLE, or someone asks CNS manifestations of SLE. Likewise, so we have to have some idea regarding the organ involvement and try to remember classes of lupus nephritis also. Somebody you may be questioned, not into the depth like histological manifestation. Some may put one or two true or false responders regularly, classes of lupus nephritis here. So, that next 36-year-old with pain and swelling of small joints of both hands and elbows of 3 months duration. Results of the investigations are as follows. Rheumatoid factor positive 1 in 360 days. ESR 15 hemoglobin 8.6, NCV 90, platelet 480. Following approval of investigation. She deserves therapy with disease modifying drugs. What do you think? Would you give disease modifying drugs? And what does the picture look like? Aisha, what does it look like? Can you hear me now? What do you think? Is the
Seronegative rheumatoid arthritis.
you think it's could be due to rheumatoid arthritis? Okay, why do you think so?
Small joints of the hands are
Yeah.
involved.
Both hands and elbows, isn't it? For 3 months. And patient has fairly high ESR, positive rheumatoid factor, and what else?
Normochromic normocytic anemia.
Yes, anormocytic
NCV
anemia.
90.
Yeah, anormocytic anemia would more likely to be due to anemia of chronic disease, isn't it? Anemia of chronic disease. So, would you like to consider demands for disease modifying agents early in this patient.
True. Yes.
Yes, you would consider it. Yes, I would mark it as true. Has bad prognostic features.
Yes, rheumatoid factor is bad prognostic.
Good. She has several poor prognostic features in the normocytic anemia, positive rheumatoid factor, significantly high T density, and symptoms going on for 3 months. So she has bad prognostic features. And if the rheumatoid factor is negative, would that rule out the diagnosis of rheumatoid arthritis?
No.
Then what would you do if the rheumatoid factor is negative and patient presents with these symptoms? Could this still be rheumatoid arthritis? Yes, this is rheumatoid factor could be negative in some patients. Rheumatoid arthritis. So any other antibody test that you know that we could do?
CCP level, anti-citrullinated peptide.
Very good. Anti-citrullinated cyclic peptide. Then nowadays, actually, EULA or European League Against Rheumatology, they have considered anti-CCP positive and anti-CCP negative rheumatoid arthritis rather than considering rheumatoid factor, because rheumatoid factor could be positive in some other inflammatory conditions and in some chronic infections like infective endocarditis even. So nowadays they go more for anti-CCP antibodies than rheumatoid factor. So rheumatoid factor could be negative even with rheumatoid arthritis. So anti-CCP negative or seronegative rheumatoid arthritis entities also there. Has high chance to have rheumatoid nodules. What do you think? Rheumatoid nodules. Those are some of the nodules you get in the, it's mainly the extensive aspect of the forearms is the rheumatoid nodules. Patients with the high disease activity, usually you see patients, these rheumatoid nodules. Somebody has high disease activity. This patient, what do you think? Are there any features that might indicate high disease activity here?
ESR is elevated.
Yeah, ESR is elevated, not very high ESR, but I would say it's slight, significant mild to moderate elevated ESR. And the normocytic anemia, isn't it? Normocytic anemia. And one of the things they have mentioned is the white cell count here. Patient may or may not have a leukocytosis. Some patient may be leukopenic even. The patients with RA. Leukopenia, if somebody is leukopenic with RA, what are the things you might suspect? White cell count එක අඩු නම් with the rheumatoid arthritis. Mainly it could be a drug-induced thing, isn't it? Leukopenia could be drug-induced as well as maybe secondary to disease itself, especially patients with Felty syndrome. With RA, they may be leukopenia. Patients who are having leukopenia, not secondary to drugs or demands given, they also considered to have a high disease activity. So patients with high disease activity may have rheumatoid nodules. So here with the normocytic anemia and high ESR, you may expect high disease activity. So rheumatoid nodules may be palpable in this patient. So next one is easily treated with iron supplements for anemia. What do you think? Iron supplement, if you give iron supplement, do you think patient's anemia would respond very quickly? Angela? would you like to give iron supplements this patient? Jamod, would you give iron supplements here? Patient seems to be anemic, isn't it? How do you think the anemia would improve? With iron supplements, if the patient is iron deficient, you would expect that.
Such a non-chronic non-cytic anemia, so it's due to the chronic inflammation. So the folic acid is the method.
Yes. Very good. Patient seems to be normocytic anemia, isn't it? MCV is normal. So in iron deficiency, what do you expect the MCV to be?
Microcytic hypochromic anemia, low MC.
Yes, low MCV, isn't it? Low MCV. So you would expect a low MCV in patient with iron. So very less likely that this patient would respond to a course of iron. So it's not really helpful. Anemia, if at all, would respond to a course of DMARDs and treatment of the underlying disease, isn't it? Sometimes, even in Kuma and Clark and Davidson, they have mentioned for chronic conditions like RA, they may give a trial of erythropoietin. Erythropoietin, the main condition where you treat anemia with erythropoietin is chronic kidney disease, but even chronic conditions like rheumatoid arthritis, you may give a trial of EPO, but very unlikely they would respond to a course of iron, especially with the normocytic anemia. So it's false, I would say. You can confidently mark it as false. Cannot be given methotrexate as she is anemic. What do you think? She is anemic, true. Cannot be given methotrexate. Buddhiman, what do you think?
False.
You would like to give methotrexate here.
Methotrexate can cause bone marrow suppression and further aggravate the condition, but in rheumatoid arthritis, it is the most commonly used medication.
Good. Yeah, good. If at all, you would try with DMARDs. Methotrexate is one of the first line DMARDs in patients with rheumatoid arthritis. So sometimes rather than causing further bone marrow suppression and making anemia, first with methotrexate, anemia might improve even, isn't it? Because you have to treat the underlying disease in any patient with anemia of chronic disease to get the improvement. So with methotrexate, anemia might further improve. But before starting methotrexate, anything you would like to see in this patient, anything else? Buddha, anything else you are interested to know before starting methotrexate? Mahika.
Whether there's a chance that the patient is pregnant or having fertility issues.
Very good. Yeah, that's the main thing I would be interested in. Whether the patient is pregnant or not and about fertility issue. You would inquire, isn't it? That's very important. Anything else? Because she's in the childbearing age, isn't it? 35-year-old female, that's fine. Regarding the pregnancy wishes and the pregnancy status, you are interested because it's contraindicated. Even it can cause some illness, but being a female in the childbearing is one of the main concerns would be regarding the pregnancy and the fertility. Any other thing you are interested in? Before starting methotrexate, to know apart from the things given here?
Liver function test.
Good. Liver function test. I am interested to see. Anything else?
Chest X-ray.
Chest X-ray. Why?
To exclude TB.
Fibrosis, pulmonary.
Yeah, because you are worried about tuberculosis as well, isn't it? You don't want to give methotrexate if she has some cavitating lesion in the lung. Isn't it? Anything else you want to know? Good. Actually, you have come up with a lot of things. Pregnancy pictures, fertility state, chest X-ray you would like to do, liver functions you are interested to know. Isn't it? Anything else? White cell count, isn't it? It's not given here. White cell count also you are very keen to know because leukopenia is one of the adverse effects of methotrexate. So we'll move on to the next one. EBV, or Epstein-Barr virus, is associated with. EBV is one of the viruses that belongs to herpes group of viruses. So the diseases it causes vary, cause wide range of diseases. EBV, starting from infectious mononucleosis like illness in children and adult teenagers, can go on to cause certain cancers. Wide range of diseases from benign to sinister. So they have asked chicken pox. Is it a disease caused by EBV?
No, false.
Good. I would mark as false. Chicken pox is not a manifestation of EBV, isn't it? So what's the virus that causes chicken pox?
Varicella zoster virus.
Good. Right. Primary cerebral lymphoma. EBV.
True.
Good. In which patient they cause primary cerebral lymphomas usually?
In immunodeficiency patient.
Yeah, immunodeficient, HIV, and AIDS mainly, isn't it? Lymphomas, cerebral lymphomas. Then they ask about nasopharyngeal carcinoma. Nasopharyngeal, see? True.
True.
Good. It's true, isn't it? Genital warts.
False.
So, what is the virus?
HPV,
Human papilloma.
papillomavirus.
Yes, good. Human papillomavirus. Is there a way to prevent HPV infections now?
Vaccination.
There's vaccination. That's right. There's vaccination for HPV. Hepatic cancer, hepatomas, hepatic carcinomas, EBV. Does it cause hepatic CS?
False.
So, do you know of any viruses that can cause hepatomas?
Hepatitis B and C.
Good. Hepatitis B, because there are certain oncogenic viruses. Hepatitis B is oncogenic, can cause hepatoma. Even in a patient without cirrhosis, they can cause hepatoma or hepatocellular carcinoma. Then HPV, human papillomavirus, is oncogenic. That can cause cervical cancers and all. Human papillomavirus. So some viruses are oncogenic. They have the tendency to cause cancers. Then EBV, can it cause some lymphomas that may cause facial disfigurement or distortion of the facial appearance? Burkitt's lymphoma, have you heard of? Burkitt's lymphoma. Fine. So, yeah, that's the thing, mainly in African children, isn't it? Burkitt's lymphoma. So, one of the things I was considering to do was you have sent some questions as well, isn't it? So shall we move on to some of those questions you have sent? Because I saw some, you have sent some interesting best of fives, isn't it? So after question number 30, we'll see some of the questions. You have sent me in a PDF, I think. So any questions from the things so far we have done? Or have you put it while I'm searching for that? We can go for the next one. Beneficial effects of weight reduction in patients with obesity. Obesity, again, one of the pet areas for your MCQ, isn't it? Reduction in deaths related to diabetes. What do you think? True or false?
True. True.
Mostly obesity leads to type 2 diabetes mellitus preceded by period of insulin resistance. So if you reduce weight in a person with obesity, there is a less risk of developing diabetes and diabetes related complications. So true. So you can reduce morbidity and mortality due to diabetes by weight reduction. Somebody who is obese, isn't it? So can you then reduction in deaths due to cancer? If somebody is obese, if you advise to reduce weight, do you think the morbidity and mortality due to cancer will be reduced?
It's
Are obese people predisposed to certain cancers? Yes, with obesity, it makes people predisposed to some cancers, mainly colonic cancers, breast cancers, and so on. By weight reduction, they can reduce the risk of developing those cancers. Reduction in bone density, beneficial effect.
false.
Why do you think? Reduction in bone density wouldn't be an advantage, isn't it? It's one of the disadvantages. Obese people are less likely to have osteoporosis compared to thin people. So, by reducing weight, somebody reduces the bone density. Also, it's a disadvantage. It predisposes them to develop fractures and also increase HDL levels. Is it a beneficial effect or a harmful effect, increasing HDL?
Beneficial effect.
Good. Yes, by reducing weight, with exercise, they can develop increased HDL. So it's beneficial. HDL is not a harmful cholesterol. Control of OSA, or obstructive sleep apnea.
True.
True.
Good. People with obesity, actually obesity is a risk factor for OSA, isn't it? That's one of the main reasons why they can have reduced lifespan compared to an obese one, compared to an obese. So you can control weight and reduce morbidity and mortality due to OSA. So with then we'll move on to some of the questions you have sent. So, who wanted this question? Can you see the screen?
No, sir.
You can't see the screen.
We can see the previous questions still.
You can see only the previous questions. So fine. Let's, because Mike had sent me some of the questions. Some of you have sent before. Let's see whether fine. So right. I think now you should be able to. Can you see now?
Yes, sir.
Good. So 35-year-old man with a BMI of 50. First rate burning pain or eyes. Difficulty in seeing at dusk and easy bruising. He also complained of abdominal pain and frequency of stools for 3 years. His investigations are as follows. HB9, MCV 104, WBC 3000, platelet 110, and RPS is 400. INR is 2. This is the best of 5. And we ask for this one. When I was doing some of the best of 5s with you, have I told how to come to the most likely diagnosis or most likely answer of the best of 5s? I think I have done in the question with the malaria, isn't it? So if you don't know the answer, one way of going through the question is get all the responses and try to consider the answer or the response which explain most of the features given in the question, most of the features. In the history examination or investigation, most of the features would be explained by one of the responses. And at the same time, consider what are the findings that is not compatible with the answer also. If one answer has more findings that are not compatible with the diagnosis, the answer is less likely to be the correct one. If one answer has more findings that are very well explained with the answer, then that becomes the correct answer. So you can cut some of the answers or just avoid some of the answers just because you can't explain more findings with that answer. Or sometimes there may be a lot of things that is not compatible with the answer. So try to remove one by one. If you don't know the exact answer, remove one by one. And sometimes even if you don't know an exact answer, sometimes the remaining one may become the correct one. So what do you think? Those who think celiac disease has celiac disease. Fine. Few hands are raising. And Okay, why do you think it's celiac disease, Erandi? Ruanar, why do you think it's celiac?
Because patient has reduced weight and he has vitamin deficiency features like pain over thighs and easy bruising, and he has diarrhea with MCV is macrocytic anemia. So that I think celiac disease.
Okay. So why do you think RBS is 400 in this patient? Fine. So some of you think it's celiac disease. One who thinks it's Crohn's disease. And some people who think it's Crohn's disease. Anyone for Crohn's? Fine. So let's see why Mahika, you think it's Crohn's.
So I said celiac.
You think it's celiac? That's fine. See, like good see you and we get fine. So anyone who thinks it's Crohn's? 3. Okay. Let's see. Chamoli. So why do you think it's Crohn's?
No, sir, I selected celiac disease.
You fine. You see the same. So anyone for Crohn's? No. Fine. Anyone for cryptosporidiosis? Cryptosporidiosis is one of the chronic ear infections mainly occur in patients with HIV/AIDS, isn't it? Immunosuppressed people. Person with a chronic diarrhea. Giardiasis. So anyone for chronic pancreatitis? Anyone for chronic pancreatitis? So no one for chronic pancreatitis. So are there anyone? Sorry. So right, Rashmi. So why do you think it's chronic pancreatitis?
So as the patient is having high level of blood sugar level and the other features are more suggestive of chronic diarrhea which causes steatorrhea and causes vitamin deficiencies, but the high blood sugar level, so I see.
High blood sugar you consider mainly chronic pancreatitis. Fine. So mainly some of you think main 2 answers you have considered by method of omission or going through the positive response, positive findings. Mainly 2 responses were there. Some of you think it's celiac disease. Some of you think it's chronic pancreatitis. So let's get those two things and try to figure out what does it more favor. So when you look at this patient, this is 35-year-old man who is really thin build, isn't it? Presenting with burning pain over thighs and difficulty in seeing at dusk and easy bruising. So this pain over thighs, why do you think he has pain over thighs? Rashmi? Pain over thighs?
Vitamin D deficiency.
Yes, osteomalacia, isn't it? Osteomalacia could cause some proximal muscle pain. Pain over thighs. Did I give you osteomalacia secondary to vitamin D malabsorption? Then difficulty in seeing at dusk. That means mainly night blindness due to what?
Vitamin A.
Vitamin A deficiency.
Good. So vitamin A also seems to be easy bruising and
Vitamin
INR
K
of 2. What does that mean? Easy bruising
Vitamin-
and INR of
Vitamin
2.
K deficiency.
K deficiency.
K deficiency.
So patient is likely to be vitamin A, B, and K. Any other vitamin that he may be deficient of apart from A, D, and K?
Folic acid.
Vitamin E.
B12.
Vitamin E, yes, folic acid, vitamin E, both are. Because then it favors some vitamin deficiency, these features, is there. So maybe a flavor of somebody having nutrient malabsorption, isn't it? Some malabsorption. So let's see. So you can explain all those with vitamin malabsorption. So mainly fat soluble vitamins get malabsorbed in certain conditions. But let's say he also complained abdominal pain and frequency of stools for 3 years. Abdominal pain and frequency of stools. So patient seems to be having some malabsorption syndrome, isn't it? Leading to vitamin deficiencies, recurrent abdominal pain and slow stools. Fine. Hemoglobin of 9 with the MC of 104 explain a macrocytic anemia. So why do you think patient is anemic, macrocytic anemia? Due to
High
Vitamin B.
B12 deficiency.
yeah, either folate or vitamin B12. One of the deficiencies could cause macrocytic anemia. So out of the two conditions, most of you have considered, which is celiac and chronic pancreatitis. Out of those two, which could cause macrocytic anemia due to folate or B12 deficiency?
celiac disease.
Celiac disease.
Okay. And patients with chronic pancreatitis also may have some macrocytic anemia.
Yes.
How?
So if it's an autoimmune cause, there can be pernicious anemia, which is also autoimmune and cause vitamin B12 deficiency.
You mean if the chronic pancreatitis is due to an autoimmune condition?
There may be concurrent other autoimmune conditions like pernicious anemia.
Yeah, that's a bit rare, isn't it? The chronic
Yeah,
pancreatitis.
rare.
Autoimmune pancreatitis, there are many other concurrent. Is there a common explanation for that than this? What are the common causes of chronic pancreatitis?
Due to
Alcohol can cause.
That's good. Alcohol is the commonest cause of chronic pancreatitis in the world, isn't it? Chronic pancreatitis most commonly caused by alcohol, whatever the area, whatever the geographic area. So alcohol can cause a macrocytic anemia.
Yeah, non-megaloblastic necrocytic anemia can be caused by alcohol.
Very good. Yes. Because macrocytosis is so high, MC is a feature of alcohol, even, isn't it? So good. Now you are thinking maybe. So that's good. So, but can celiac disease explain macrocytic anemia? How can it explain? You thought it can cause macrocytic. How does it cause macrocytic anemia?
Due to folate deficiency.
Due to folate deficiency. Yes, you are there. So what is the commonest form of anemia do patients with celiac disease develop? Is it macrocytic anemia or microcytic anemia?
Microcytic anemia.
Why? Do they develop commonly microcytic or macrocytic, and why? Yes, I agree with you. Commonly develop microcytic anemia due to iron deficiencies. Iron does get absorbed in the early part of the small bowel or in the duodenal region and the early jejunum. There the celiac disease process starts. So commonly they are deficient of iron. Iron deficiency anemia is one of the common modes of presentation in patients with celiac disease. So that may be the only presenting manifestation. So they more commonly they develop iron deficiency compared to folate deficiency, but they can be deficient of both. Even celiac anemia there. So that's good. That's one of the things we have to keep in mind. Then if we go to WBC and platelets, both WBC and platelets are low, isn't it? So how can you explain low WBC and platelets both in patients with celiac? Can we have pancytopenia? Both WBC and platelets low. Because, as you said, they may develop some folate deficiencies. Folate deficiency could lead to leukopenia, thrombocytopenia, anemia. Or isn't it? They can be pancytopenia as well due to folate, underlying folate deficiency. And can patients with chronic pancreatitis be pancytopenia? Chronic pancreatitis enable pancytopenia to the full one. Not directly, isn't it? If you consider underlying causes of chronic pancreatitis, maybe alcohol, they may be having some thrombocytopenia, and due to hypertension, there may be some leukopenia as well. But there is no direct relationship. They also may be deficient, nutritionally deficient before they causing this pancytopenia, but they, unlike in celiac, there is no direct. And RBC of 400, that indicates they are significantly hyperglycemic, isn't it? Severe hyperglycemia in that. So, with celiac, can you explain RBC of 400?
No, sir.
Anyone?
Celiac disease can associate with insulin dependent diabetes mellitus due to pancreatic insufficiency.
Can celiac explain RBC of 400?
No, sir.
Yes, I agree with the explanation given before, because type 1 diabetes can be associated with celiac disease. Type 1 diabetes is again one of the autoimmune conditions. So there may be coexisting type 1 diabetes as well as celiac. So RDSO 400 may be explained with the type 1 diabetes associated with celiac. So INR of 2 very likely to be due to underlying vitamin K deficiency given the history of malabsorption. So malabsorption of vitamin A, B, K can they commonly occur with celiac disease. Fat malabsorption is the prominent feature in celiac disease.
I didn't get your questions.
It is malabsorption of fat soluble vitamins A, D, K, commonly seen with celiac. Which part of the bowel usually get affects with the celiac disease? It's the is it the distal part of the small bowel or the proximal?
Distal parts.
Proximal.
Distal part of the small bowel.
Proximal part.
Yeah, proximal, isn't it? Proximal. In which part of the intestine this vitamin A, D, K get absorbed usually with the bile acids?
The distal part, ileum region.
Yeah.
Ileum.
And it's terminal ileum area. So considering those arguments out of celiac and chronic pancreatitis, what is the diagnosis which could explain most of the things easily?
Chronic pancreatitis.
Yes, I would also have chronic pancreatitis there because of the maldigestion of fat. They would develop these vitamin deficiencies, and they are having severe hyperglycemia as well. And the cytopenias also could be explained. But only thing is, having said that, this is one of the difficult questions I agree. Even for celiac disease, sometimes we might end up giving marks, but the answer expected here mainly is a chronic pancreatitis. I agree because patient with celiac develop abdominal pain and loose stools as well. But those are this history of abdominal pain and frequency of stools for 3 years, these features of vitamin deficiencies and the severe hyperglycemia is more, the flavor is more chronic pancreatitis than celiac disease. With the clinical presentation of, considering the clinical presentation of all disease. But even if you argue for celiac disease, yes, theoretically you can explain all this with celiac even, but common presentation of, if you consider common presentation, it more explains with chronic pancreatitis. So I would mark for chronic pancreatitis if I was given the best of 5. Did you understand that one?
Yes, sir.
Okay, good. So I agree it's a difficult question, isn't it? One of the questions that would be a bit difficult. But it checks whether you are aware about the common presentation of both the diseases. But good that you have excluded the unlikely answers. That's also, I'm happy you considered celiac and chronic pancreatitis instead of considering cryptosporidiosis or giardiasis. Good. So next one, 50-year-old farmer, the diarrhea for 6 months and difficulty in standing from squatting position. Is it? I think it has squatting position, isn't it? Squatting position. So he's having bilateral thigh pain and bleeding under the skin. Bleeding under the skin in both thighs, isn't it? Most appropriate investigation. So what do you think the most appropriate? So what is the flavor like? Gives a history of chronic diarrhea, isn't it? Looks like a malabsorptive syndrome again. Malabsorption is the difficulty in standing up from squatting position due to osteomalacia again, causing proximal muscle weakness, proximal myopathy due to vitamin D deficiency, bilateral thigh pain again. Thigh pain favors some osteomalacia. Bleeding under the skin could be due to underlying vitamin K deficiencies, causing some coagulopathy. And history goes on going on for 6 months. So to identify the etiology, what you would do, which one of the investigations you think might identify the etiology? And from where did you get this question? From 35th, isn't it? Is it from 35th?
Yes, sir.
35th. Okay. Let's see. So who thinks actually to find out, because you would do a full blood count. And some those who think full blood count. Fine. I think there seems to be a stool full report. Who think is a stool full report? Stool full report taking. පුළුවන් වේද course එක හොයන්න. So fine, dealing one things is a stool full report. So only 2 people. Including also think it's stool full report, that's fine. Ultrasound abdomen, anyone? Anyone for ultrasound abdomen? Stool culture, serum electrolytes. Okay, you can go with the method of omission if you are not really sure, isn't it? Go with the method of omission if you are not really. So if you do a stool culture, would you think you would be able to identify the cause? Seems that patient is having a malabsorption syndrome. Malabsorption syndromes can be caused by chronic infections, but less likely, isn't it? Less likely. So the full blood count, how do you think? How do you think it would be? I think one thought is two people thought is a full blood count. Would you like to explain why did you think so? Come on, isn't it? So why did you think it's a full word count? How do you think it would explain?
Sorry, sir.
So you thought the full word count you would be able to identify the cause of his present. Why did you think so?
I selected ultrasound abdomens.
Use it. So fine. So sorry, who selected the full word count? Fine. So why did you select ultrasound abdomen?
Because this patient has a history suggestive of malabsorption syndrome, and with the history, background history of chronic diarrhea, and also ask the most appropriate investigation to find out the cause. So I think that to find out the cause, like the pancreatitis, the ultrasound scan, abdomen.
Patient has a chronic diarrhea and some malabsorption. So you would do an ultrasound abdomen to find out whether the patient is having chronic pancreatitis. Is it?
Yes. Yes.
Fine. So anyone else who thinks ultrasound abdomen? Hands up. Those who think ultrasound abdomen. So Ruan are also pleased with the investigation of ultrasound abdomen. Anyone for stool full report? Again, it's a bit of a tricky question. It's a difficult question because if you go by the investigations given here, one of the ways to check here is if you do any of these investigations, can you come to a conclusion, or can you come to a conclusion of what more likely causing the presentation, diarrhea and some malabsorption? Even if you do a stool report, you might end up seeing some pus cells, red cells, and maybe some fat globules, but it may not take you to the cause of underlying malabsorption, isn't it? Even if you do a full blood count, you might see some microcytic or macrocytic anemia with some other cytopenias. Again, it may not take you to underlying cause. You might do a stool culture, which may or may not grow underlying, may or may not grow an organism. Again, may not be something. Serum electrolyte, again, you might do, but it may not give you a clue regarding the underlying cause. So all things investigating full blood count, stool full report, stool culture, serum, you do in this patient definitely if you are managing, but none of those things would take you to the underlying cause of the malabsorption. They would actually tell you there is an underlying malabsorption. But considering the history of chronic diarrhea and some vitamin deficiency, if you do some abdomen, you might find out some clue for the underlying disease, which is chronic pancreatitis. So I also would agree with that answer. But again, this is a very tricky question and a difficult one, isn't it? May not be that easy. So the next one, 45-year-old patient with chronic liver cell disease coming with ascites despite treatment with diuretics. Peritoneal tap reveals lymphocytes. There's a lympho count of 75, RBC 150, and SAG 11. Serum ascitic albumin gradient 11. Gradually, most probable diagnosis. Portal vein thrombosis. Those who think portal vein thrombosis is cancer. No one. Then those who think Budd-Chiari syndrome, cancer. Those who think SBP, spontaneous bacterial peritonitis, cancer. Those who think TB peritonitis. Fine. There are some people who think it's TB peritonitis. Then those who think autoimmune peritonitis. Those were the answers. That's fine. So let's go back to those who think TB peritonitis. So, Aisha, why do you think it's TB peritonitis?
Sorry, sir.
Why did you think it's TB peritonitis? What made you to think TB?
SAG value of 11 grams with lymphocytosis and of peritoneal tap.
Yes. Good. Because SAG, here they have made it a bit difficult by keeping SAG at 11 because there is a low SAG, maybe we call low SAG ascites and high SAG ascites. If the SAG is less than 1.1 or less than 11, it favors the cause of ascites is not due to underlying portal hypertension, isn't it? If the SAG is more than 11, that favors the cause of ascites is due to underlying portal hypertension. But here they have made SAG at 11, making it difficult because the demarcation they have given at 11, that is less than 11 no more than. But there are some other features is the patient having an ongoing chronic liver cell disease treated with diuretics. If the patient is compliant with diet and the diuretics, you expect ascites to improve. But here they have mentioned clearly ascites is not improving due to some other reason. But they kept SAG at 11, making it difficult. But at the same time, they have given lymphocyte count is 75 and RBC 150. So considering predominant lymphocytic ascites, lymphocytic response in the cellular response, and RBC of 150 with the non-resolving ascites favors and tuberculosis, but here they have mentioned something like hepatoma, then I would consider that as correct. SBP is out mainly because you will see predominant polymorphonuclear lymphocyte count of more than 250. So that's how you come to a conclusion. Looking at everything, so I would also mark as TB peritonitis. That's true. Fine. Any question on those things we have done so far? Or have you understood?
So if it is more than 11, can we take other two as well answers?
If it was more than 11.
11, that means towards the portal hypertension.
Yes. If it was more than 11, but
can we take the Budd-Chiari and portal vein thrombosis both as true or With lymphocyte, it is impossible.
Again, if it was more than 11, then I would think this, if it was more than 11, then I would think this ascites is mainly produced by portal hypertension, not due to an alternative cause. But only thing, if there was a lympho count of 75 and RBC of 150, with the SARC of more than 11, again it favors there is some underlying other disease contributing to the ascites. But again, it's a bit of a difficult question to answer. The SARC had been more than 11, you may consider conditions like portal hypertension associated things like portal vein thrombosis and Budd-Chiari syndrome. But again, you won't get a lymphocytic predominant and an RBC of 150. But hepatoma, yes, I would consider hepatoma. If the SARC of more than 11 developing a very difficult to control ascites with the lymphocyte count predominant in the ascitic fluid, hepatoma I would have considered. If the answer was there, then you might have had a more difficulty, but not mainly portal vein thrombosis or Budd-Chiari. But hepatoma here, they haven't put, isn't it? If they have put hepatoma, then that also could be taken as one of the correct answers. But look, going through the 5 responses, TB peritonitis is the only one you can take here, not the other ones.
So if it's a hepatoma, how can it cause a transudate? If it's more than 11, it's a transudate.
Yeah, that's the thing. Because things, when it comes to ascitic fluid, rather than mentioning it the transudate or an exudate, what we are interested at is low SARC and high SARC ascites. If there's ascitic fluid is a high SARC ascitic fluid, it indicates rather than mentioning transudate or exudate, it indicates there is underlying portal hypertension. If SARC is more than 11, if SARC is less than 11, it says underlying cause of ascites has to be something else than portal hypertension. Hepatoma do develop mainly in patients with portal hypertension, isn't it? You know that. Hepatomas usually develop in patients with portal hypertension. Rarely can be there even without portal hypertension and cirrhosis in patients with hepatitis B, since it's an oncogenic virus, as we have already discussed today. But mainly you develop hepatomas in a patient who has a background of portal hypertension or high SARC ascites. When they develop hepatoma, one of the main ways they manifest is a tense ascites, difficult to control with the diet and diuretics. And ascitic fluid is usually hemorrhagic and have some lymphocytes. So even with the SARC of more than 11, as you said, you may consider a transudate, but even with SARC of more than 11, they may have a hepatoma. So that's why you could make this question more tricky if you have put the answer, one of the answers as hepatoma.
Yes.
Did I answer the question?
Yes, sir. Thank you.
So go by low SARC and high SARC ascites. When there is a SARC, when there is ascitic fluid analysis, go by the SARC, whether the ascitic fluid is low SARC or high SARC, rather than considering it as a transudate or exudate, and in the case of pleural fluid. So if everybody understood how we arrived at the diagnosis of TB peritonitis.
Yes.
Was that the main difficulty you had, isn't it?
Yes, so it's if it is going to given as 11, we have to take it as LOSAG.
That's the thing. You can't take it as LOSAG because that's one of the difficulties in this question, isn't it? Because LOSAG you go by less than 11, right? If you go through the textbooks, many textbooks, standard textbook, LOSAG is given as less than 11, high SAG is given as more than 11, right? So more than 11 means there is a portal hypertension. That's why they have given it as 11. So this may be the low SAG or high SAG. But in the question they have mentioned patient has a CLCD with ascites. Patient anyway has cirrhosis with ascites. So ascites is due to portal hypertension. But the question is why the patient's ascites is not responding with maximal diuretics. And at the same time, they have given lymphocytic ascitic fluid with the RBC of 150. So in a patient with portal hypertension, ascites is not responding due to some underlying other secondary cause. That secondary cause is likely to be tuberculosis out of the responses given. Okay, not purely you are taking this as a low SAG ascites and deciding it's a TB.
Okay.
So that's why this question is a bit tricky, I would say. But having seen the responses, you have to take it as TB peritonitis.
Okay, sir.
Okay. Then, what do you think? So, since time is little bit late, isn't it? In 40 almost. So we can do, since some of you feeling a bit sleepy, shall we do the rest of the questions on another day? Okay. Because it's okay with me, but I think since some of you may be getting a bit sleepy, then we can do in another day. But one of the other problems I have found out, because I can't scroll down this PDF beyond question number 3. Have you put more questions after the question number 32? Or does it finishes at 32?
So there are about 25 questions in the PDF.
Yeah, that's one of the other problems I had, because beyond question number 32, I can't see other questions. So would you be able to resend the other questions?
Okay, so I'll send it.
Fine. If you can resend those questions and any other questions you get from the previous MCQs, difficult ones, you are good mainly because most of the questions you have answered really well. So you have much improved than what it was when we have started. So we'll try to do it on another day. And try to resend me the other questions beyond 32. Okay then. You think it was beneficial or was it difficult to understand? Because there may be some difficulties with sound and all, isn't it? Unlike in a conventional lecture theatre one, isn't it? But let's try to actually. But what I could hear, some of you didn't hear, isn't it? I don't know what's the reason. So were all of you had a difficulty in seeing, or only some of you difficulty in hearing mainly? Probably when I speak closer to the mic, you were hearing a bit clear, isn't it? Okay then. So, fine. Thank you for hearing patiently. We'll try to meet on another day and do the rest of it. Okay.
Okay, sir.
Okay. Good night.
Good night, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you,
Thank you, sir.
sir.